Today I am going to talk about something about IBD, inflammatory bowel disease. So inflammatory bowel disease contains Crohn's disease and ulcerative colitis. It is affecting more commonly in females rather than males. It is bimodal age distribution as it is told in the textbooks, but it is now there is no age as I told you. So that is some of the things. Etiology is not known clearly. The etiology is not studied or clearly known. But the etiology known to be is a hypothesis known as hygiene hypothesis. Hygiene hypothesis is known to be the etiology what is said to be, but there is no proper etiology. What is this hygiene hypothesis? Hygiene hypothesis is the poor development of the mucosal immunity, poor immunity of the or poor development of the mucosa, you can say, which can result in something known as hygiene hypothesis. Okay, so that can be the reason is what it is told to be. And there are many genetic factors like there are some genes like NOD2 gene, NOD2 gene polymorphism can be a result, a genetic factor. NOD2 gene polymorphism, what happens, there is a activation of the growth signaling pathway resulting in increase in the cell proliferation and resulting in the IBD, inflammatory bowel disease. So one of the factor can be NOD2 gene polymorphism. The second one can be ATG16L1, ATG16L1. That is ATG means autophagy related 16L1. Okay, autophagy related 16L1. That is one of the genetic factor. Then comes IL-23 gene polymorphism. Interleukin 23 gene polymorphism can be one of the genetic factor. And one more thing is IRGM. IRGM means immunity related GTPS-M. So these are the four genetic factors that can be a etiology or pathogenesis of the IBD, inflammatory bowel disease. So etiology is not clearly known, but it can be a hygiene hypothesis. The pathogenesis can be these things. So now coming one by one, what is the most common site where you can see Crohn's disease? Crohn's disease, the maximum site, the most common site you can say, most common site of Crohn's disease is in the ileum. Then comes the cecum. So ileum and the cecum. Okay. Whereas in ulcerative colitis, the most common site is rectum. Rectum, it can go upwards. It is retrograde in spread. So from the rectum, it goes to the colon. So it is going backwards. So it is a retrograde spread which affects the ulcerative colitis. So ileum in Crohn's disease and rectum is the most common site in ulcerative colitis, which is retrograde spread. Now coming to the layers which affects. Crohn's disease affects transmurally. It affects all the layers of the stomach, mean the mucosa, submucosa, muscularis layer, serosa layer, every layer. It is transmural. So the incision, the ulcers will be deep. It's like a knife, like ulcers will be there. So most common site is ileum. The layers affected transmural, it is transmurally affected, transmural it is, whereas ulcerative colitis it is the rectum, the most common site is rectum, whereas the lesion it is like submucous, it is affecting the submucous layer. So transmural layer is Crohn's disease and submucous layer is affected the ulcerative colitis. Now coming to the growth structure, when you take Crohn's disease, first I'll talk about Crohn's disease now. Okay, in between it is coming because some of the things are common there. So Crohn's disease, as I told, it is most common site is ileum. It can affect cecum also. It is transmural. Whereas when you take a growth structure, what you can see the characteristic, the primary thing what you see is aphthous ulcers. You can see aphthous ulcers as the primary finding or primary feature in the growth structure. Aphthous ulcers. These aphthous ulcers can coalesce together and it can form a serpentine ulcer. It can lead to serpentine ulcers. These aphthous ulcers coalesce together and it forms serpentine ulcers. You can see something known as creeping fat. The mesenteric fat oozes out and it surrounds the layers there. It forms the creeping fat. Creeping fat is one of the features you can see in Crohn's disease. And one more thing what you classically see when you take the intestine, that particular, the ileum or the affected structure, the ileum or the cecum, you can see the cobblestone appearance. It's like a cobblestone appearance. I think you can know what is cobblestone. So you can see cobblestone appearance of the intestine can be seen, of the mucosa can be seen. Cobblestone appearance of mucosa is a classical or a characteristic symptom or feature of the gross feature of the Crohn's disease. Then there will be a rubbery thick intestine. The intestine will be rubbery, the intestine will be rubbery thick. Okay, that is one of the things. Then there is something called skip lesions. It's not continuous, it's skip lesions. Some lesions are here, then it won't be nothing, it will be normal, then it comes in. So that's why it says cobblestone appearance. Cobblestone, stone is there, nothing is there, again one more stone is there. So it's a skip lesions. Skip lesions can be seen in Crohn's disease. So these are some of the classical thing grossly you can see. What about the microscopic features? So microscopic features, the main thing you can see is non-caseating granulomas. Non-caseating granulomas are the classical thing you can see in a microscopic feature. Then the next thing what you see is, you can see cryptitis, you can see cryptic abscess. Okay, cryptitis, and you can see cryptic abscess. So the one more, the other microscopic feature, when you have a barium scan, you can see a sign known as string sign of Cantor. String sign of Cantor, K-A-N-T-O-R. String sign of Cantor is one of the finding. A barium, when you see it, take the barium scan, you can see string sign of Cantor. So that's about something about Crohn's disease. Now coming to ulcerative colitis. As I told you, most common site of ulcerative colitis is rectum followed by colon, because from the rectum it goes retrograde spread to the colon. Okay, so it's a backwash ileitis can happen. Backwash ileitis, it's going back to the colon to the ileum, terminal ileum. So from rectum it can go to the colon, it can affect the colon, it can even affect the terminal ileum. That is known as backwash ileitis. Okay, so ulcerative colitis most common site is rectum followed by colon, retrograde spread. The layer affected is submucosal layer, and you can see backwash ileitis. The most common thing you can see pseudopolyps. So in Crohn's we have aphthous ulcer. Here we have in ulcerative colitis we have pseudopolyps. Pseudopolyps can be seen as a characteristic feature, as a main gross feature of the ulcerative colitis. Also you can see cryptitis and cryptic abscess. So cryptitis, cryptic abscess is more common in ulcerative colitis than the Crohn's disease. It can be seen in both, but it is more common in ulcerative colitis. So pseudopolyps, cryptitis, cryptic abscess can be seen. The pseudopolyps actually it fuse with each other, forming mucosal bridges. They can form bridges known as mucosal bridges. This pseudopolyps fuses with each other and form mucosal bridges. So ulcerative colitis is also known as toxic megacolon. The other name for ulcerative colitis is toxic megacolon. That you have to keep in your mind. Toxic megacolon is also known as ulcerative colitis. So now right now Crohn's disease is there. Gross feature of Crohn's disease, microscopic feature of Crohn's disease, gross feature of ulcerative colitis, microscopic feature of ulcerative colitis. Now coming to the clinical feature of IBD. IBD itself, the clinical feature of inflammatory bowel disease. First one, you can see fever, you can see abdominal pain, you can see diarrhea. Okay, so fever, abdominal pain, diarrhea are the main classical symptoms, but you cannot say fever, abdominal pain, diarrhea, anything it can happen. Gastrointestinal symptoms, anything, even food poisoning can be there. So that itself is not a symptom. So fever, abdominal pain, diarrhea has to be there. That is the three main symptoms. Along with that, you have extra-intestinal manifestations. You have many other manifestations. Extra-intestinal means you can affect dermatologically. You can see manifestation. You can get hepatobiliary manifestations there, musculoskeletal, renal. Okay, so then these many manifestations can ophthalmic manifestations. So these many are extra-intestinal manifestations. In that, dermatologically you can see erythema nodosum is a classical thing. What you can see, erythema nodosum can be seen as a dermatological manifestation in IBD. Ophthalmic, you can see uveitis, iritis can be seen. Okay, renal, you can see calcium oxalate nephrolithiasis can be seen. Musculoskeletal, when you take ankylosing spondylitis, some kind of arthritis, some of the arthritis, I don't remember exactly the name. So arthritis is the common thing symptom. There are many types of arthritis. So especially saying ankylosing spondylitis can be a manifestation seen in ulcerative colitis. Then hematologically, it can affect even the hematology, blood, anemia. Anemia can be a reason. Thrombocytopenia, thrombocytosis, all this can be a result or manifestation of a IBD, inflammatory bowel disease. Hepatobiliary, primary sclerosing cholangitis. Primary sclerosing cholangitis is a classical manifestation seen as a hepatobiliary manifestation. Along with that, you can see fatty liver. So these things can be seen as extra-intestinal manifestations of IBD. So fever, diarrhea, abdominal pain with extra-intestinal manifestations are the symptoms of the clinical feature of IBD. Now diagnosing or investigation, you can say there are antibodies to diagnose. The test can be done. Then scanning, you can do CECT scan abdomen, CECT scan abdomen, CECT abdomen can be done, MRI can be done, CECT, any abdominal thing, CT is the gold standard, CECT is the gold standard. You can do as a investigation of inflammatory bowel disease. Colonoscopy, endoscopy with colonoscopy, that's the main thing first you do. Endoscopy with colonoscopy can be done. So these are the main thing. And also ulcerative colitis, if IBD is not treated, it can go to colon cancer. That has to be ruled out. So colonoscopy is one of the important investigations. So colonoscopy is done. to rule out colon cancer, because the risk of colon cancer is more than IBD. According to the recent researchers, risk of colon cancer is more in IBD. So you have to make sure, if you have an IBD, you have to make sure it doesn't go to colon cancer. You have to take a protective preventive. You cannot prevent the further thing you can prevent. The treatment wise, you can see, I am coming to the management now. Management, how can you manage this particular thing? The classical thing is steroids is being given. Steroids as enema can be given per orally or IV. That is a management what we usually treat for the IBD. It is management by giving steroids as enemas. I hope you know enema. Enema can as per orally or IV. Then the other thing can be monoclonal antibodies can be given, like infliximab. That can be given. Then the other thing is sulfasalazine. Sulfasalazine can be given as a treatment. So if you have steroid side effective, the steroids are not affected, then next comes the surgical resection. Surgical procedure like proctocolectomy can be done with anastomosis. Exact anastomosis, some specific name is there, I don't remember. So proctocolectomy is the procedure can be done. Okay, proctocolectomy with anastomosis of the terminal ileum area. So proctocolectomy is a thing what we do as a surgical thing. So surgical resection complete is a main line of treatment in ulcerative colitis. That can be done. And one more thing I have forgot to tell is ulcerative colitis is a continuous lesion compared to Crohn's disease. Crohn's disease was a skip lesion.